Hi, everybody, and welcome to our Health and Action work group today. My name is Rachel, and I'm one of the MVC Site Engagement Coordinators. It's my pleasure to be facilitating the work group with you today. This is just a preview of what we're going to be going through at the work group today. I will go over our housekeeping and some P4P credit reminders. We will follow that with a presentation by Corewell Health Farmington Hills on their surgical site infection improvement initiative. And then we'll have a little bit of time for a discussion where you can ask any questions you like. And then we'll end the work group with some MVC upcoming events and updates. Our housekeeping items, just a reminder that we do record these work group sessions. The slides and the recording will be available to you after the work group. We'll send an email with the slides and the link to the YouTube video. And then the video is on our YouTube channel. You can always go there and access that as well. A reminder to please mute your microphone during the presentation unless you have a question. In that case, you can use the raise hand feature. And then any questions that you have throughout the presentation, you can feel free to put in the chat, and we will definitely make sure to go through those during our discussion portion of the work group. For our P4P participating sites, just a reminder that we'd like you to have active participation. That means participating in the discussion, asking questions, or even giving answers to questions other members have. And then also completing our post-work group survey. At the end of the work group, we'll be sharing a link in the chat for you to fill out that survey. The survey is also great for non-P4P sites to use as well. It just gives us a really good idea of what you liked about the work group, or if you have any suggestions for future work groups. Today's presenters, we are joined by Jenny Henge. Jenny is currently serving as an internal quality improvement specialist senior at Corewell Health Farmington Hills. She focuses on advancing patient safety through evidence-based practices. She's a graduate of Eastern Michigan University with a Bachelor of Science in Nursing. Jenny brings extensive clinical experience as an OR circulator, along with expertise in surgical site infection prevention and healthcare informatics. She's deeply committed to reducing patient safety indicators by implementing targeted interventions, fostering education, and driving collaborative strategies across teams to ensure the highest standards of care. We're also joined by Leslie Smith. Leslie is a clinical pharmacist specialist at Corewell Health Farmington Hills. She specializes in antibiotic stewardship and infectious diseases. She's a graduate of Wayne State University College of Pharmacy. Leslie is committed to optimizing antimicrobial prescribing and usage to improve patient outcomes and reduce resistance within the hospital setting. Her work focuses on evidence-based interventions, provider education, and collaborative strategies to ensure safe and effective antimicrobial therapy. We're also going to hopefully be joined by a third presenter. He is not entirely sure if he'll make it or not. Dr. Eugene Lavaroni. He is a vascular surgeon at Corewell Health Farmington Hills. In addition to serving as chief of surgery, he has held numerous leadership roles, including chairman of the Surgical Quality Committee. Dr. Lavaroni has actively contributed as a physician champion in several Michigan statewide quality collaborations. His unwavering commitment to patient safety and quality improvement reflects his passion for advancing surgical care and outcomes. And with that, I'll be passing the presentation over to Jenny.
Thank you, Rachel. And thank you again, Rachel, Emily, Jessica, for inviting us to be a part of this today. We were honored and excited about it. So today I'm going to talk about the challenges we went through in the rewards about how we were able to reduce surgical site infections at Corewell Farmington Hills. Next slide, please. So Corewell Health is the largest health system in Michigan. And that's because we merged Spectrum and Beaumont Health together in 2022. We have 64,000 team members, probably out of that 1,500 physicians and 11,500 physicians and 15,000 nurses. We have about 21 hospitals and 300 outpatient locations. We also have a insurance arm called Priority Health. So we're in the East region, Corewell Health East, and that's Farmington Hills. And we have about 2,000 healthcare team members, 305 licensed bed. And we're also a level 2 trauma center, which very proud of. And then we're located, I'm not sure if people are familiar with Farmington Hills, Michigan. So we get a large demographics of patients from different areas. So our mission statement is to improve health, instill humanity, and inspire hope. And how we're going to get there is really with our values of everybody working as a team with compassion, collaboration, clarity, curiosity when we're researching or doing our discovery process, and courage. Next slide, please. So the NHSN is the platform that everyone has to use, all hospitals, for surgical site infections. And it's required by the Centers for Medicare and Medicaid Services. We must report our SSI data for colon procedures as well as abdominal HIS. And it is a value-based purchasing program and hospital acquired conditions penalty programs. Next slide. So when we start researching or discovery, we look at CDC studies, and we were reading with inpatient surgeries in 2015, they estimated about 110,000 surgical site infections. And then in 2023, it looked like a 2% increase in that standardized infection ratio. And then they broke it down to even with improved sterilization methods, barriers, surgical technique, equipment, everything across the board, there would still an account for 20% of associated SSIs, and 75% of those SSIs were death related, attributed to the SSI. So we looked at us, and we noted that we were at like 9% with SSI colorectal surgeries. Next slide. So what were we going to do? Well, after looking at us in April, we knew we were about 9.62, which was a high percentage. So we knew we had to reduce the number of surgical site infections for our patients within colorectal surgeries. But you had to ask, how are you going to do this? Because it doesn't take one. It takes a village, and who would those experts be to help us? So the next slide is the beginning of a committee. I thought it was important to bring in our vascular chief surgeon, Leslie Smith, and myself. And yes, Dr. Lavaroni is vascular surgeon, and he doesn't see those colos. However, he is also the chief of our surgical quality committee. So we were bringing this forth to him. As we learned over the months and years, we were adding people to our committee. We had the surgical educator, Michelle Schaefer, the pharmacy that works in the OR, Colleen Foley. And then we also had to add anesthesiologists. Next slide. This was the hardest part, the discovery. We had to figure out what was going on. So it wasn't meant to be punitive, but we needed to learn, were they using new clean gloves, gowns, what we call closing packs, prior to closing the patient after an abdominal colo surgery? We also were looking at what preps were you using? We were looking at start time of antibiotics, and also any other reasons that we think might have contributed to this SSI um, hit. So, and then we kind of looked over here at our comparison in 22 and 2023. SIPs aren't reported, the superficial infection, but organ space is, and deep incisional primaries are. So when you looked at 22 and 23, it really didn't change much, and we rolled up what we thought was the issues and still struggling with what was it going to be. Next slide. So what we knew we had to do right away is educate monthly at our S-clips where Dr. Lavaroni was the chair. We had to identify when the surgeon noted an infection that was present at time of surgery and where it should be documented. And the example I can give you there is this is very important because one patient had a colonoscopy. The surgeon documented in their PATOS, ended up doing an XLAP, didn't document it in the operative note in the XLAP because he thought it was okay that it was in the colonoscopy and it wasn't. So that minor thing, we knew it was present on admission, but it wasn't documented in the right place. The other thing we were doing as we saw these SSIs, we were sending out a letter to the physician, letting them know, and surgeons, that we reviewed their chart and that they did hit for an SSI, and this is why we think they did. It could have been skin prep, antibiotics, we're not sure. The home where the patient goes to, we just didn't know. The other thing we have is an OR and endo newsletter. And we were reporting like we did not have closing packs. But what it was an item difference between the east and west sites. So we went on to one item number, and then our director of education made sure that it was listed on every pick sheet for every surgeon that was going to do abdominal surgery or hysterectomy. Next slide. So we identified the areas of improvement. We saw PATOS. We also talked about the skin closure techniques and the prepping. And we did see little improvement, but it wasn't impactful. It just a little bit of improvement. And again, this is the hardest part, is the discovery part. Well, then we started looking at the antibiotic type and timing, how long it was infused for the patient. And this is where we really made a difference. And I am honored and very proud to hand over the mic to you, Leslie, because you were an excellent contributor to the committee, and your expertise on surgical antibiotics really hit it home. So go ahead, Leslie.
All right. Thank you, Jenny. So phase one of our project, when we looked at antibiotics, we're calling it Give Cefazolin. Go to the next slide. So when I am asked to evaluate antibiotic prophylaxis prior to surgery, this is what I look at. Was an appropriate antibiotic given for the type of surgery, and that includes the dose. If an alternative antibiotic, so again, if the first line antibiotic was not given, why was that alternative given? Was the timing appropriate? And this also becomes important during our journey. So according to national guidelines, you have to administer antibiotics within 60 minutes of skin incision. The exceptions to that are vancomycin and fluoroquinolones, such as ciprofloxacin and levofloxacin. You can administer them within 2 hours, and the reason is that it takes them longer to infuse. So most antibiotics you must administer within 60 minutes, and then the last thing was redosing indicated. So that is the lens I'm looking at. So the next slide shows you a case that, I'm sorry. This slide shows you what our recommended antibiotics were for colosurgery. So our recommended agent is cefazolin plus metronidazole, our Flagyl. Our alternative was Flagyl and Gent. The next slide shows This was a case Jenny asked me to look at where the patient, this was reported as an SSI to NHSN. So just a little bit about this case. This was an elective non-trauma case. The patient came in and he was having a lot done. He was having a cystoscopy along with a catheter insertion, an exploratory lap right hemcolectomy. So he was having a colo case. This particular patient had an allergy listed to penicillin, which also becomes important, which was rash itching. So when I looked at our antibiotics, this patient got Flagyl and gentamicin. Doses were appropriate, but we considered these our second line. So the question is, why didn't this patient get our first line, which is cefazolin? So we wanted cefazolin instead of gen. And the reason was because of this penicillin allergy. So the doctor was concerned about this penicillin cephalosporin allergy. Is that a valid concern? And the answer is no. And we're going to go over the education that we actually provided to our surgeons. So again, when I looked at this, we saw two issues. The patient got second line antibiotics and our drugs were not fully infused prior to surgery skin incision. So two issued. Another reason why we like cefazolin so much is that we administer it IV push at our institution. So it can go in very, very quickly over 3 to 5 minutes. These secondary or alternative antibiotics that we administered must be administered over 30 minutes. So again, that complicates things. Way easier to give cefazolin IV push. Let's go to the next slide. So we're going to really focus on this case. So because we knew that we had an issue with penicillin allergies and given our first line cefazolin, this is the education that we gave to our surgeons. So 90% of patients who report a penicillin are not truly allergic. And one of the reasons for that is you outgrow it. If you had a penicillin as a child or even an adult, you will outgrow that, or 80% of patients will outgrow that within 10 years. So basically, you can get it and then you're no longer allergic. And we know that penicillin allergic patients are 3 times more likely to experience an adverse drug event. The next slide sort of breaks those down. These are the consequences if you have a penicillin allergy and they avoid given first-line drugs like cefazolin. And you can see an increase in MRSA, an increased risk in vancomycin resistance enterococci, longer hospital admissions, higher rates of admissions, a significant increase in C. diff. But again, we're focusing on this increased surgical site infection risk. So the next slide is some studies that we presented to our team that went over this. So the first study here was over 8,300 patients at Mass General Hospital. They underwent hip or knee arthroplasty, hysterectomy, colon surgery, again, that's what we care about here, and CABG. And 11% of them had a penicillin allergy. But what was the bottom line? The bottom line is patients who had a reported penicillin allergy had a 50% increased odds of a surgery site infection attributable to the receipt of second-line perioperative antibiotics. So again, this was eye-opening for a lot of our surgeons because they thought we're still giving antibiotics, everything's fine. And it's like, no, our patients are at increased risk if we don't give them our first-line cefazolin. If you go to the next slide, this was another study at 7,700 patients at Mayo Clinic. These were patients undergoing shoulder arthroplasty. And again, what did it show? Cefazolin administration was associated with a significantly lower rate of prosthetic joint infections compared with non-cefazolin alternatives such as vanco and clindamycin. So again, we presented, here's the evidence. The next slide, I was just curious, is there anything newer out there? So this is gigantic, almost 350,000 patients. So this was from 175 hospital in Switzerland, and you can see they underwent numerous surgeries. And again, what did this find? Non-beta-lactam surgical antibiotics should be avoided whenever possible. So there's tons of literature out there that basically say you have to go with the beta-lactam antibiotics such as cefazolin over these alternatives. So the next slide, the question is, can we really give cefazolin to someone that's penicillin allergic? And so we have thought historically, everyone thought that it was this beta-lactam ring, and because both penicillins and cephalosporins have this beta-lactam ring, that is what caused the cross sensitivity. However, that is old school thought, and they have since discovered it's really this R1 side chain. So it's the similarity in the R1 side chain, not the beta lactam ring, that determines if you're going to have a cross reaction between penicillins and cephalosporins. If you look at the other two examples, they're monobactams, that's ace-trionum, and carbapenems, ertapenem, meropenem. We have historically given both those agents to penicillin allergic patients without batting an eye, even though that they had that same beta-lactam ring. So again, it's the R1 side chain that we have to focus on. Go to the next slide. So this is a chart that basically compares penicillins and selects cephalosporins. And you will notice in red, cefazolin has a completely unique R side chain. Cefazolin, that means that cefazolin will not cross-react with any penicillin or any other cephalosporin that is available in the United States because of this unique R side chain. And again, that is what determines if there's going to be a cross reaction. Go to the next slide. So, is it safe? So the next question is, historically, we've always avoided cephalosporins if there's a penicillin allergy. Is it safe to give cefazolin if we have a patient that's penicillin allergic? And this is what this study showed. Again, administration of cefazolin and penicillin anaphylactic patients. Again, one of the most severe reactions you can have, anaphylaxis, and they said it's safe. So again, makes sense, right? Because we know now it's the R1 side chain, completely unique for cefazolin. Go to the next slide. This study actually looked at patients, do you have a dual allergy to penicillins and cefazolin? And again, they basically said the low frequency of penicillin, cefazolin dual allergies suggests that most patients should receive cefazolin regardless of penicillin allergy history. So again, this makes sense again now that we know it's that R1 side chain and cefazolin has a completely unique R1 side chain. Go to the next slide. So one of our barriers was in our Epic computer system, if you entered a drug, any cephalosporin like cefazolin, and they had a penicillin allergy, the provider would get a contraindication allergy alert. So this was one of our gigantic barriers because we started telling our surgeons, please ignore that. It's not accurate. We want you to give cefazolin. So this was one of our gigantic barriers at the time. It's like we're telling physicians to ignore alerts, and you never really want to ignore alert. I'm pleased to say that as of July 21st, 2024, that alert has been removed. So now if a patient has a penicillin allergy and they put cefazolin, there's no allergy contraindication alert. So the next question is, well, is that really safe? Because we removed it, not just for cefazolin, it's removed for all cephalosporins. So was that safe? Go to the next slide. So, of course, there's literature on exactly this. So at Kaiser Permanente in California, they removed that cephalosporin penicillin allergy at half their sites, and they kept the warning at the other half. What happened? A 47 increase ordering of cephalosporins across the board. This is not just in surgery, this is across the board for all indications. So what did they find? No significant differences in anaphylaxis or new allergies or treatment failures. So again, there's literature supporting removing this penicillin cephalosporin allergy alert. The next slide is from our friends, the experts in allergy. So to the American College of Allergy, Asthma, and Immunology and the American Academy of Allergy, Asthma, and Immunology, very similar, but two different organizations came out with a new drug allergy practice parameter in 2022. So what does the allergy experts say? They say the same thing. So again, CBS 12 for patients with a history of anaphylaxis to penicillin, a structurally dissimilar R1 side chain cephalosporin can be administered without testing or additional precautions. So again, what does that mean? Remember, cefazolin has a completely unique R1 side chain. So the allergy experts are telling us it's safe to give cefazolin if you have a penicillin allergy. Their CBS 13 says that if it's an unverified non-anaphylactoid penicillin allergy, a cephalosporin can be administered without testing or additional precautions. So again, the allergy experts are now endorsing this also. So again, it's not the beta-lactam ring that determines allergy, it's this R1 side chain. Go to the next slide. So our case conclusion on the case was that our surgical prophylaxis antibiotic administration was not optimized in this patient. This patient should have received cefazolin, and they received Gent and Sed. Why? Less risk of surgery site infections, versus alternatives. And again, we can administer cefazolin over 3 to 5 minutes versus the 30 minutes it took for the gentamicin. And again, in our case, they started the skin incision before the gent was fully infused. So again, we know the timing. So again, we said phase 1 was we had to get cefazolin, and then we were going to work on phase 2. So phase 1, go to the next slide, is go with cefazolin. So that was the new direction that we wanted our surgeons to go. And the bottom line is almost all patients with penicillin allergies, including anaphylaxis, can safely and should receive cefazolin. Now, there is an exception to this. There are very few rare patients that have a history of a severe non-IgE allergy, such as DRESS, Stevens-Johnson 10s. Those we don't want to get cefazolin. So, but pretty much everyone across the board, or not everyone, most patients, we want them to go with cefazolin. So that was phase 1. So phase 2, next slide, is we knew we needed to work on the antibiotic timing because the case we started out with, we also had antibiotic timing issues. So now we're going to talk about what we did to address antibiotic timing. So at our institution, our antibiotic prophylaxis are ordered by our surgeons or the surgery residents. So the first part was focused on them, getting them to order. The second part is the administration of antibiotics was more. And we found that we were not optimizing our Flagyl administration. Remember, Flagyl goes over 30 minutes. And if you look at some of these cases here, we had Flagyl given 6 minutes before surgery or before the skin incision, 10 minutes before skin incision. So this was telling us that Flagyl was not fully infused prior to skin incision. If you look at the Ancef or cefazolin, again, this is given IV push over 3 to 5 minutes. So all those times were fine. So we knew we had a timing issue from the initial case. And then when we looked at cases and these cases did not have an SSI, but we knew we had a problem that we needed to address. If you go to the next slide. So this is what we did. This is the educational flyer that we developed with our new workflow. So the goal of the new workflow was that all our preoperative antibiotics would be completely infused prior to the surgical timeout. Vanco, Cipro, and levofloxacin, again, those are the ones that we have 2 hours to give prior to the incision. So those are the ones that we wanted the pre-op nurse to start. So we came up with this memory aid called I Love Pre-op, which stood for Infuse Levofloxacin Cipro Arvanco in pre-op. So that was the memory aid to help the pre-op nurse know which 3 antibiotics that they should actually start infusion. Our other antibiotics that are listed there, all were in mini bags, are IV piggybacks that infused over 30 minutes. So the new workflow, and before what was happening is that the nurse laid the piggyback on the patient, they wheeled the patient into OR, and then our anesthesia started this. So this is why they were not infusing prior to skin incision. So the new workflow was that the pre-op nurse prepares any piggyback other than the vancomycin on a dial-a-flow and hangs it on a bed pole. And then the CRNA starts the infusion at pre-op sign out. And then we continued with our cefazolin, again, because that's IV push. That one continued to be administered by anesthesia at induction. If you look at that second point under cefazolin, again, we re-emphasized on this educational flyer about the penicillin allergy and that almost all patients could receive cefazolin. The ones we excluded, again, if they had an unknown cephalosporin allergy. So again, some of our patients, there's just a generic cephalosporin, and if the patient didn't know which one, we didn't want to risk giving cefazolin, or again, those with this non-severe IgE allergy, such as Stevens-Johnson's TENS dress. So again, that was the workflow that we established. I'm going to go to the next slide. As part of this, we also developed this flyer that really simplified the previous flyer. So again, Vanco, Cipro, Levaquin, you can see 90 minutes infusion time. And then we did the blue, all our other piggybacks, pre-op sign-off, and then the yellow, cefazolin and stuff right at surgical or anesthesia. So we place this on our Omnicell and pass this out to our pre-op nurses. So this was the simplified flyer. In addition, on the next slide, because we have Omnicells, we were able to put little reminders in our Omnicell. So when the nurse went to pull out cefazolin, it reminded her that anesthesia was going to administer that at induction. The second slide, again, is all our piggybacks that we administered over 30 minutes. It reminded him, put that on a dial-a-flow, hang on the bed pole. And then that last alert was for vancomycin, Cipro, and Levaquin, which again, those take longer to infuse, that the pre-op nurse was going to hang it and infuse it. So we also did alerts in our Omnicell. Go to the next slide. So in conclusion, we talked about peak tissue issues, again, how we wanted our antibiotics totally infused prior to skin incision. Our preferred antibiotics for colocases and hysterectomies are cefazolin and Flagyl. And we also addressed, as part of this project, what about patients who are currently on antibiotics in the hospital and then are going for surgery? What do we do with those patients? And so we have a chart on the next page that we're going to review. And basically, if the spectrum of the antibiotic regimen is already appropriate, then potentially we could just give an additional dose of that. So again, that's, I'm going to go to the next slide so you can see our redosing table. So we went through and we did redosing. When should you redose? For patients who are having surgery and they're already on antibiotics, or in patients whose surgery was delayed, because sometimes we have surgery that's delayed. And if you look at piperacillin and tazobactam, that's Zosyn, that has a very short half-life. And during surgeries, you redose at 2 half-lives. So again, if a patient had normal renal function and they were on Zosyn, we would want that redosed within 2 hours. So we did this as part of our quality improvement, or expanded this as part of our quality. This was already information that we were using for our anesthesias when they redose and prolong surgeries. And we're like, we already have this great chart. Why aren't we expanding this? And so this expansion was put into our updated, at the time, Beaumont surgical guidelines. Next slide. And I'm going to turn it back to Jenny. Jenny, you're muted.
Sorry. Great job, Leslie. Excellent. So this is, in closing, I wanted to let everyone know the outcome of this project that was really a long project. We met monthly, we scrubbed charts, we went back to the start of it like, well, that didn't really change anything much. We had one surgeon who refused to use flagell, and she had a couple surgical site infections. So when we implemented this and we made it, this is what you have to use, she has not had a surgical site infection. So, you know, I know physicians have their own ideas and evidence-based practice, but we really rely on the research, what it tells us and everything that Leslie went through. Next slide. So this was the outcome. The prevention time frame, you can see we were at 9.62%. We went back and forth with interventions from May of 2023 through January 2024. And like I said, it did move the needle a little bit, but not as impactful as we wanted it to. And then as soon as Leslie did a road training with all our resident meeting, medicine meetings, surgery about why to use Kefsol and Flagyl, we did not have a surgical site infection throughout that time after. This was post-intervention. It truly made a difference. This year, I think we did have 1 or 2 in 2025 surgical site infections, but they did go to peer review. Standard of care was met. All guidelines were followed. It, you know, could have been something else, but, you know, it's not a perfect world, but the good news to us was they did follow the national guidelines and then all the other education as well, that with prepping the skin, using a closing pack, etc. Next slide. This was our biggest win. And that little mascot up there is Clarity. So what made this a win is Clarity. When she appeared, she reminds us that we need all the subject matter experts. 1 person, 2 people, 5 people don't have all the answers. So we bring people in with our struggle. And when we tell them the why, they're dedicated and they want to help. So we did have a diverse committee united in purpose, bringing their expertise and passion to work. I also wanted to add, you know, Corewell is a big corporation, you know, largest medical system in Michigan. But everybody should be reminded that you can drive meaningful quality at your own site regarding patient safety improvements, still within a large complex organization. It can be done. And then it's important that Clarity appears to say, how do we take this to all the other sites across the region? And then the positive trend, of course, highlights an opportunity to communicate and collaborate to the other sites to improve health, instill humanity, and inspire hope at Corewell Health, which is our mission statement. So I think that was it.
Yeah, thank you so much, you guys. That was a really
Mhm.
great presentation. We're going to move into our discussion and question time. And just so everybody's aware, the references that were cited in the presentation are going to be on a slide that will be shared with you in the email afterwards. All right, and with that, we're going to open it up to questions. I know that there were some coming in through the chat, so let's see. It looks like Jenny, you replied to this one. Um, I'll read it out loud and then we can maybe have you answer it out loud too, just so everybody hears it. So Catherine asked, did you have to coordinate contacting the surgeons with the infection prevention team? If I remember correctly, they work with the NHSN data as well. And then Jenny, do you want me to read
Uh,
your answer or do you want to just answer? Say?
Well, I can just say, yeah,
Yeah.
that was a great question because again, and as a reminder, it takes a village, and external quality was a big part in supporting what we were doing by giving us the heads up that an SSI was reported to NHSN. So that put us in the discovery of really scrubbing that chart, taking it to peer review, learning what could have been done better, or maybe everything was done right. But it also gave us the opportunity to add to the timeout, the time the antibiotics were given to ensure infusion time, especially on Flagyl. And then also the circulator in the room um, does a debrief with the surgeon. So he or she is aware that infection um, could be there. So they remind the surgeon to say, was this patos or how do you want me to document this? But it also helps them how they're going to remind them how they're going to document it in the OR report. So excellent teamwork between the nurse and the surgeon in the OR suite too.
Wonderful. So we have another question slash scenario from Jennifer. She says, here's the scenario. Inpatient is on scheduled antibiotic that does not require redosing. They receive scheduled dose on the inpatient floor, go to surgery, and the next dose is due while in surgery. Um, Hold on, this thing is in my way. So Epic, the OR team cannot see scheduled inpatient meds. The inpatient MAR is placed on auto hold. How do you ensure continuity of antibiotic administration in this scenario?
You're muted, Leslie. Ha.
Can you go back to the chart? Because
Oh
I'm
yeah,
going to go a couple slides back.
give me a second. This one?
Yes.
Okay.
So I'm just going to say that we have your scenario doesn't happen very often, unfortunately, because anesthesia has said to us, like, let's say the patient's on cefepime on the floor and they come down. They're like, we just rather give a dose of cefazolin within the hour so we know that we're covered. So your scenario is not happening a lot. Sometimes if they're on ceftriaxone that has a very long half-life, you don't have to redose that at all. Sometimes if they're on ceftriaxone, they'll skip the cefazolin, but for the most part, they're still giving the recommended antibiotics just for the scenario you provided. And we know that two of them, the very one at the top, ampicillin sulbactam, which is brand name Unison, and again, our piperacillin tazobactam zosyn, because those require redosing in 2 hours, even if they're on either one of those antibiotics, they almost will always give the recommended antibiotics and pre-op because those require redosing so long. There's pros and cons with that. Like we're giving an extra antibiotic. Every extra antibiotic you give increases the risk of C. diff, but that is what our anesthesiologists are doing. Where this chart has really come in helpful is our patients who come in through the ER. So They come in through the ER for whatever reason, and our ER, for instance, starts antibiotics. And a lot of time they will start piperacillin tazobactam because it's broad spectrum. So again, this is super helpful. Like, oh, it's been 3 hours. Are we covered? Are we not? So this is like a reminder, like, no, piperacillin tazo, we redose at 2 hours. So this is really helpful to sort of help steer thoughts. Do I want to give another dose? Don't I? Do I want to go with the preferred antibiotic for this surgery, even though piperacillin covers everything cefazolin does plus more? So I hope that helped.
Thanks, Leslie. I have a question from Erica. She is wondering, was this SSI data discussed within a section group meeting to allow for physicians to see others were open to changes?
Yes, and I thought, oh, yeah, no, I'm not muted. I thought that was an excellent question because we have a lot of passionate attendings, residents, and anesthesiologists, pathology that attend our surgical quality peer review meeting monthly. And that's as we're reviewing these cases, that's when one surgeon said, I don't use Flagyl. And she was part of that 9.34 percent of SSIs that were reported to NHSN. So she learned from her surgical peers that Flagyl must be given and infused prior to the surgical cut. And this surgeon had 0 SSIs in 2025. And that's when she started using Flagyl. I think it was fall of 2024. And she finally started adding it and 0. So it
Awesome.
made a difference for her.
Wonderful. And then I have a question from Anne. Do you document colon bundle items in Epic, or do you track them on paper, like Alexis O-ring, separate closing set, etc.? If so, do you follow up with surgeons that fall out of bundle compliance?
So that's another great question. And Michelle Schaefer, the educator, is who I worked with to add the bundle pack as an item number on every surgeon pick sheet. And so the surgical scrub tech knows that this is going to be open prior to closing. It is tracked in Epic.
Wonderful. And Kate has a comment. She says, just wanted to say how much I enjoyed your antibiotics racing to the finish line flyer. It's great when learning can be fun and can make the information more memorable.
Absolutely. And pre-op, I think, Leslie, you can add to this, love their acronym too.
Yes,
I mean,
they
they're
love.
still using it. So
Yeah. So I can tell you, it was proposed to us. I didn't come up with us. One of the anesthesiologists did, who wasn't part of this bundle, that is actually, though, our medical director of quality and safety. And he was over meeting with me about something else. And he knew about this project, but he wasn't directly involved. And he's the one on the fly that came up with that I love pre-op. And so when we proposed it to the anesthesiologists who were part of our work group, they did not like it. And they're like, no, no, no. But when we talked about it with nursing, some of the nursing to run it by them, they all loved it.
mhm,
So we kept it in the flyer because the nursing feedback was like, no, we love this. I love pre-op
mhm.
memory aid. So just again, different opinions because our 2 anesthesiologists wanted to scrap it.
Yeah. And it was motivational for those nurses too. It didn't just serve its purpose of what they needed to do, but they were motivated, I love pre-op, and another one would say it, so it
Yeah,
was a good thing.
wonderful. And then Emily just shared in the chat that she thinks this is definitely a worthwhile presentation that could be shared with several of our other CQIs. So keep that in mind. You guys might be open to doing another presentation on it. Are there any other questions? I'm gonna kind of move the slides back towards the end again. All right. Well, that was a pretty great discussion time, question answer time. Thanks, everyone. I'm going to move into our MVC upcoming events. We have our work groups coming up in February, and we have a cardiac rehab work group on Tuesday, February 10th. This is going to be a panelist style work group where we'll have several cardiac rehab experts joining us, and we'll have kind of a guided discussion and question answer time. And they'll be from multiple different sites, MVC member sites. And then following that, in February, we have our virtual networking event, which we actually do have the date for now. That is going to be Thursday, February 26th, from 12 to 1:30. And it's going to be focused on a topic that is called relational coordination. And Emily Waltman, our project manager, is going to be heading up the presentation with a colleague of hers. She did a lot of research in this field, and in relation to how relational coordination can be used within healthcare, and building stronger teams within systems. So really looking forward to that. We're going to have a presentation by her and her colleague, a discussion time, and then we'll have a guided breakout session kind of focused on that topic. So really looking forward to it. And then following that, we have our rural health work group and post-discharge follow-up work group in March. We are looking for presenters, so if anyone is interested, feel free to send us a message or fill out the presentation proposal form. We'd love to hear from you. And then moving on, some of our upcoming updates, like I mentioned, our virtual networking event registration is open. The link for that will be in the email for you guys. And our 2025 engagement reports are now ready to view on the registry. If you don't have access to the registry, please give us an email and we'll try to get you set up. And if you have any difficulties with viewing the report on the registry, please let us know and we'll try to help problem solve that. And otherwise, I think that is all for today. Emily's going to put the link in the chat for the post-work group survey. It was really great having you, Jenny and Leslie. Thank you so much for presenting. It was a lot of great information. And then thanks for everybody for joining us.
And thank you for having us, and thank you to all the listeners. Have a good week.
Have a great week, everybody. Thank you.
Thank you.